I want you to think back just for a second to a time when you were in a really vulnerable situation.
Right.
Like maybe you were sitting in a hospital ER,
Really?
or you were on the phone with a crisis hotline.
Yeah, those really high stress moments.
Exactly. And do you remember that specific moment when a complete stranger, like a nurse or a counselor, just walked into the room and within minutes you felt this like profound sense of ease?
Like you could just finally exhale.
Yes. You
Mm.
probably walked away assuming that person was simply, a naturally gifted, empathetic soul. Like they just had the magic touch.
Oh, absolutely. We tend to romanticize that kind of human connection, right? We assume it's just instinct.
Right. But the reality is actually far more clinical. That feeling of instant trust isn't magic.
Hmm.
It's usually the result of highly engineered, testable
It's
mechanics.
a very specific skill set.
Yeah, known as therapeutic communication. And that is our mission for this deep dive. We're unpacking the deliberate architecture that healthcare providers use to get patients to open up.
And the underlying psychology of these techniques is something you can actually apply to your own everyday conversations.
Which is the best part. We got some fascinating sources on the table today, ranging from modern nursing textbooks to historical psychiatric literature from the 50s, all the way to current bioethics journals.
It's a really rich area of study.
It is. So to understand how this architecture works, we have to establish a baseline. Like, therapeutic communication is fundamentally different from just a normal social chat.
Oh, completely.
Because in everyday life, a conversation is reciprocal, right?
Yeah.
Both people are seeking connection or validation, or they're just, passing the time.
Right, but the clinical literature defines therapeutic communication as strictly goal-directed.
Goal-directed.
Yes, I mean, every pause, every shift in posture, every single question is deployed to serve the patient's needs, not the provider's comfort.
So it's not about making friends.
Not at all. It is literally treated as a clinical intervention. You're using communication as a form of medicine to establish rapport, get accurate diagnostic info, and help the patient problem solve.
Okay, so the first major hurdle a clinician faces in doing that is just getting past the patient's internal filter.
Yes, the filter's huge.
Because when someone walks into a clinic, they almost never offer the raw, unedited truth right away.
No, they're terrified. Or embarrassed.
Right, they edit their answers based on fear or just the really intimidating power dynamics of, sitting half naked in a paper gown while someone stands over you with a laptop.
Yeah, it's not a natural environment.
No. So bypassing that filter requires actually manipulating the boundaries of the conversation.
And this is where we look at textbooks on interpersonal relationships in nursing. Like, the widely cited work by Arnold and Boggs focuses heavily on the actual literal framing of questions.
Like the mechanics of the sentences.
Exactly. A core intervention they teach is swapping out closed questions for open-ended ones, because it completely changes the cognitive load on the patient.
How so?
Well, think about it. If a nurse asks, "Are you in pain?" that closed question primes a one-word answer.
Right, yes or no.
And more importantly, it gives a patient who minimizes their discomfort an easy out.
Oh, wow. Yeah, they just say no so they don't bother the busy doctor.
Precisely.
Yeah.
But if the nurse says, "Tell me what you're feeling right now," they shift the mental task. The patient isn't just answering a binary prompt anymore. They have to narrate an experience.
They had to tell a story.
Right. And in that narrative, the patient might casually bring up, debilitating nausea or severe anxiety about paying for their meds' vital clinical data that a yes or no question would have just permanently buried.
It really reminds me of dealing with poorly designed automated tech support.
Oh, gosh, yes.
Like when your internet goes down and the robot voice is like, "Are you calling because your router is blinking red? Say yes or no."
But it's not blinking red.
Exactly. It's completely dead. But the prompt forces you into this binary box that doesn't actually capture your problem.
This is a perfect analogy. A closed clinical question traps a patient in a diagnostic box of the clinician's own making.
It prevents them from revealing what's actually wrong.
You're predetermining the boundaries of their experience before they even get to speak.
That's wild.
Yeah, and another mechanical shift that changes the patient's response is just replacing the word why with what or how.
Wait, really? Just dropping the word why?
Just that one word. Asking a patient, "Why didn't you take your medication?" almost guarantees they get defensive.
Well, yeah, it sounds judgy.
It does. From a psychological standpoint, the word why often triggers the amygdala, the part of the brain associated with threat detection. It literally sounds like an accusation demanding a justification.
So the patient feels like they're being interrogated for a crime,
Exactly.
and they just shut down. Or they make up an excuse.
Right, but if the provider simply asks, what got in the way of taking your medication, they change the neurological response entirely.
Oh, wow. What got in the way?
Yeah. By framing the obstacle as an external what, you bypass the defensive reaction. You engage the prefrontal cortex, which handles objective problem solving,
So the blame is totally removed from the patient.
and placed on the external factor. The patient transitions from being like a suspect defending their character to a partner solving a logistical puzzle.
That structural shift makes total sense. But, okay, there is another tool in the literature that seems completely counterintuitive to me.
Oh, I know where you're going with this.
Yeah, the use of deliberate silence.
Yes, silence.
Like, silence is formally classified as an active clinical technique, not just a gap between sentences.
It's an active, powerful tool, but the education literature shows that novice clinicians are absolutely terrified of it.
I mean, I would be too.
Research on new nurses shows they consistently panic when a patient discloses something really heavy. If a patient says, I'm terrified of dying, the novice will typically tolerate only 1 or 2 seconds of silence before they just jump in and start speaking.
Because the natural human instinct is to fill that dead air.
Right.
When someone tells you they're terrified, you want to instantly fix it. You want to say, don't worry, the doctors are great, you're going to be okay.
And that instinct to fill the space is exactly what clinical education tries to train out of providers.
Really?
Yeah, because that urge usually results in what they call false reassurance.
False reassurance, okay.
Saying everything will be fine when you don't actually know the prognosis, that only serves to relieve the clinician's own discomfort with the awkward silence. It does nothing for the patient's anxiety.
Oh, I see.
False reassurance is basically a conversational dead end. It sends the message that the patient's fear is an inconvenience.
It totally invalidates what they just told you.
It dismisses their reality completely. Patients actually need processing time. The literature suggests a minimum of 5 to 6 seconds of uninterrupted silence after a difficult disclosure.
6 seconds. That is an agonizingly long time to just sit there in silence.
It feels like an eternity. But they need that neurological lag time to process their own emotions, to formulate their next thought, or honestly just to cry.
Wow.
By deliberately maintaining silence, the provider is actively holding space. They're signaling that it is safe for the patient to keep exploring that really difficult feeling.
It's just so striking to me that holding space and trying to get the patient's unedited truth is the gold standard today. Because if you look at the history of the medical establishment,
Oh, it's a totally different world.
yeah, there was a long period where the prevailing consensus was that truthful communication was actively detrimental to a patient's health.
It's hard to believe now, but the history of therapeutic communication is rooted in this deeply paternalistic era. There's this landmark study published in the Journal of the American Medical Association back in 1961 by a physician named Donald Oken.
The Oken study, yeah.
He surveyed practicing doctors about their communication habits, and he found that roughly 90% of them routinely withheld cancer diagnoses from their patients.
90%. They would literally tell the patient's family, but intentionally lied to the patient sitting right there in the bed.
Yeah, and this wasn't driven by malice. It was just rooted in the bioethical framework of the time.
They thought they were helping.
Exactly. The prevailing wisdom was that patients lacked the psychological resilience to handle terminal news. Doctors genuinely believed that full disclosure would destroy a patient's hope.
And accelerate their physical decline.
Right. Paternalism dictated that the physician's duty to protect the patient from harm was way more important than the patient's right to know what was happening to their own body. Silence and deception were used as protective clinical tools.
Which is just wild to think about. But that paradigm obviously collapsed.
Thankfully, yes.
Because by the 70s and 80s, the sources indicate a total inversion. The rise of the consumer rights movement and modern bioethics established patient autonomy as the paramount right.
It was a massive cultural shift.
Yeah, and replications of Oken's study a couple of decades later showed the numbers had entirely flipped. The vast majority of physicians were suddenly favoring full disclosure.
So the control of the narrative shifted fundamentally from the provider to the patient. But the actual mechanics of how to conduct these therapeutic relationships, that traces back to the post-war psychiatric wards.
Okay, let's get into that.
So Hildegard Pepla, a World War II Army nurse, is really considered a pioneer here. In 1952, she published this huge work called Interpersonal Relations in Nursing.
And she was heavily influenced by Harry Stack Sullivan's theories on interpersonal psychiatry, right?
Exactly. Pepla argued something incredibly radical for the time. She said the nurse-patient relationship itself was the treatment.
Which was huge because nursing at the time was so highly task-oriented.
It was just checking boxes.
Yeah, administering pills, changing dressings, following orders. But Petitpla elevated the interaction itself to a therapeutic level.
She did.
And she designed this famous four-phase model for the clinical relationship, right? Orientation, identification, exploitation, and resolution.
Those are the four.
Now, the first two make total sense to me. Orientation is just setting the parameters of care, and identification is the patient starting to trust the nurse.
Right.
But that third phase, exploitation, that sounds incredibly toxic in a healthcare setting. What does that actually mean?
I know the terminology really reflects the era, and it can sound super jarring today. But in Pepla's framework, exploitation refers to the patient's constructive use of the relationship.
Constructive use, okay.
Once trust is established, the patient actively exploits or uses the resources, the time, and the clinical expertise of the nurse to work through their own health challenges.
So they're milking the system for their own good.
Exactly. It is the phase of maximum patient empowerment. They are extracting value from the healthcare system for their own healing.
Okay, that makes way more sense.
And then the final phase, resolution, involves carefully severing that therapeutic tie as the patient gets better and returns to independence.
So the patient is leveraging the relationship for their own benefit. And following Pepla, the sources show a really strong integration of psychological theories into nursing.
Oh, heavily. The work of psychologist Carl Rogers is central here.
Right, from the early 60s.
Yeah, in 1961, he introduced the three core conditions for therapy: empathy, unconditional positive regard, and congruence, which basically means genuineness.
Being authentic.
Right. And then nurse theorist Joyce Travelby synthesized these ideas in 1971, coining this amazing concept called the therapeutic use of self.
Which means what, exactly?
It suggests that a provider's disciplined presence is actually a clinical instrument. It requires the clinician to stay self-aware and consciously use their personality, their tone, and their emotional regulation as an intervention.
But relying purely on a provider's emotional intelligence became a huge liability once truth-telling was mandated, didn't it?
Oh, for sure.
Because when doctors were suddenly required to deliver devastating news, doing it without a structured framework led to disastrous outcomes.
Clinicians under pressure would just panic.
Right. They'd deliver the news way too bluntly, or they'd retreat behind this wall of dense medical jargon. They needed to engineer actual protocols for these high-stakes conversations.
Because empathy without structure can easily lead to psychological trauma for the patient.
Exactly.
And that necessity birthed frameworks like the Spikes Protocol, which was published by Walter Bale and his colleagues around 2000. It was specifically designed for oncology, for breaking bad news.
Right, and it's an acronym.
Yes, it walks the clinician through a very deliberate psychological pacing.
So the steps are setting, perception, invitation, knowledge, emotions, and strategy.
That's right.
And the PPS reception seems particularly crucial for pacing the conversation.
Oh, it's vital. The perception step requires a clinician to ask the patient what they already believe is happening before delivering the news.
So asking something like, what have you been told so far about your MRI results?
Exactly. It forces the clinician to calibrate the delivery. Because if the patient firmly believes they are just there for a routine scan, the clinician instantly knows they have to bridge a massive psychological gap.
You have to find out where the patient is on the map before you can safely guide them to this terrible new destination.
That's a great way to put it.
And then the I invitation takes it a step further by actually asking for permission to share the data.
Yes. The clinician asks, are you someone who wants all the medical details, or would you prefer I just focus on the big picture and the treatment plan?
Wow, that is so respectful.
It really is. It respects the patient's autonomy and their cognitive limits in that exact awful moment.
Right.
Then, in the case step knowledge, the provider gives the facts in small, digestible chunks. They avoid jargon, and they pause frequently.
Which prevents that anxiety-driven beta dump that overwhelmed doctors usually default to.
Exactly. Now, there is another high-stakes framework that focuses on instruction rather than bad news, and it addresses the massive problem of health literacy.
Oh, the teach-back method.
Yes. Patients routinely nod along to discharge instructions, like how to manage a surgical drain or take a complex set of pills, without actually understanding a word of it.
Because no one wants to look stupid.
Right. But the teach-back method completely bypasses that fear.
Because instead of a nurse asking, "Do you understand?" which inevitably prompts a defensive yes,
Yeah.
the provider shifts the burden of clarity.
They put it on themselves.
Yeah, they say, "Just so I know I explained this well, can you tell me how you'll take this medication when you get home?"
It's brilliant. It is an evaluation of the provider's communication skills, not the patient's intelligence.
Exactly. If the patient explains it incorrectly, they don't feel ashamed. They just assume the nurse needs to clarify.
It opens the door for correction without damaging that rapport.
It's such a great psychological trick. But, the proven success of frameworks like Spikes and Teachback has sparked a really heated debate in modern nursing education.
The scripting debate.
Yes, because if scripting certain interactions improves outcomes, hospital administrators naturally want to standardize and script as much of the bedside experience as possible.
Which leads directly into the authenticity trap.
Right, because hospital customer service initiatives have heavily promoted programs like ATET, right? Acknowledge, introduce, duration, explanation, and thank you.
Yeah, popularized by the Studer Group. It provides nurses with these highly structured, almost verbatim scripts for interacting with patients.
And hospital systems love it.
Because it's measurable. And it often yields short-term gains in patient satisfaction scores. But critics in publications like the Journal of Clinical Nursing argue that aggressive scripting creates hollow empathy.
Hollow empathy.
Yeah. It violates Carl Rogers' core rule of congruence. If a provider recites a scripted line like, "I understand this must be very difficult for you," but their tone and body language don't genuinely reflect that sentiment,
Patients instantly detect it.
they absolutely know it's fake.
It feels like getting one of those automated apologies from an airline app when your flight is canceled,
Yes.
as opposed to a human being actually looking at you and genuinely acknowledging how frustrating it is.
Huge difference.
This tension between genuine connection and professional distance really brings up the clinical distinction between empathy and sympathy.
Which is a crucial distinction.
Because in a casual setting, we use those words totally interchangeably. But the nursing literature draws a hard boundary.
They represent two entirely different psychological mechanisms. Empathy requires accurately perceiving a patient's emotional state and reflecting it back to them. You validate their experience without absorbing their distress as your own.
It operates like a mirror.
Exactly. Sympathy, on the other hand, is feeling sorry for the patient. It is rooted in pity.
And pity creates weird dynamics.
It inherently establishes a power imbalance. When you pity someone, you distance yourself from their suffering, creating this wall between provider and patient.
So sympathy isolates, but empathy connects.
Bingo.
Speaking of communication misconceptions, we have to address this pervasive myth that appears in, like, every corporate seminar and self-help book ever written.
Oh, I bet I know which one.
The idea that 93% of communication is nonverbal.
Ah, yes. The Morabian myth.
It implies that the actual words you use barely matter compared to your vibe or your body language.
And nursing education actively works to debunk this because it is a deeply dangerous misapplication of a very narrow psychological study.
So where did it come from?
Well, back in 1967, a psychologist named Albert Morabian conducted research where subjects listened to a recording of a single neutral word like the word maybe,
Okay.
but it was spoken in a tone of voice that clearly conflicted with the word's meaning, while they looked at a facial expression that also conflicted.
Oh, got it. So if someone is aggressively shouting the word fine, you believe the shouting, not the vocabulary.
Exactly that. Morabian's formula only applies to situations where emotional cues are incongruent. It absolutely does not mean that 93% of all human communication is nonverbal.
That's a massive distortion.
It is. The words carry the critical diagnostic data. Think about it. If a patient quietly says, "My chest feels like it's tearing," but their body language appears calm.
If the nurse ignores the words because the nonverbal vibe seems chill, they're making a fatal error.
A severe clinical error. Words matter immensely.
Recognizing that words matter and that communication breakdowns are literally the leading cause of adverse events and malpractice claims in hospitals, the medical field has developed tools to ensure critical data isn't lost.
Which is why we have things like SBR.
SBR, yeah. Situation, background, assessment, recommendation.
Right. SBR is a standardized structural tool used during handoffs, like when one nurse finishes a shift and passes a patient to the next nurse.
It forces the communication out of a messy, chaotic narrative and into a rigid sequence.
You state the immediate problem, the relevant history, your clinical assessment, and what you think needs to happen next. It eliminates the guesswork.
So cognitive overload doesn't cause a provider to just drop a vital piece of context.
Precisely.
Another really fascinating application of these mechanics is motivational interviewing.
Oh, I love motivational interviewing.
It's used heavily in primary care for behavior change, right?
Yeah.
Like getting a patient to quit smoking or change their diet.
Yes.
Instead of lecturing the patient on the dangers of smoking, which, as we know, triggers that defensive amygdala response.
Oh, why trigger?
Right. Instead, the provider uses open-ended questions to evoke the patient's own reasons for wanting to change.
It is explicitly designed to resolve ambivalence. By carefully guiding the conversation, the provider helps the patient articulate their own intrinsic motivations.
Because when the patient hears themselves argue for the change,
It is infinitely more effective than a doctor just wagging a finger and telling them what to do.
it's brilliant. And, the mechanics of therapeutic communication, motivational interviewing, the teach-back method, using what instead of why, and just holding space with silence, these aren't just for clinicians.
No, they apply directly to our everyday lives.
Totally. Like, if you are supporting a grieving friend, your first instinct might be to offer false reassurance. You might want to say, "At least you had so many good years together," or "Everything happens for a reason."
And in a clinical context, we know those phrases function as total conversation killers.
They shut the person down.
They invalidate the person's current distress. Applying therapeutic communication in real life means learning to just sit in the awkward silence.
Let it be awkward.
Use open-ended questions to let them narrate their grief, and mirror their emotions through true empathy, rather than distancing yourself with pity and sympathy.
It really forces you to reevaluate how you handle every difficult conversation.
It does.
To close out this deep dive, the bioethics journals present a final, really provocative thought regarding how we handle information today.
This is a fascinating debate right now.
Yeah, because we discussed how paternalism and lying to patients in the 60s was highly unethical. But some modern bioethicists argue that the pendulum of informed consent may have swung way too far into blunt transparency.
Right. The current ethical discussion really centers on this concept of asking before telling.
Asking before telling.
Yes. Rather than assuming that full, unvarnished transparency is always the most therapeutic approach, clinicians are exploring whether a patient's appetite for devastating information should actually be elicited first.
It challenges the assumption that radical honesty is always the highest moral good.
It really complicates things.
It does, because sometimes the most trust-building thing you can do isn't just dropping the blunt truth on someone because you feel legally or morally obligated to. It's carefully asking them how much of the truth they actually want to carry in that exact moment.
And when they give you their answer.
You give them the 6 seconds of silence they need to process it. Because the ability to instantly put someone at ease isn't magic. It is an architecture of empathy, and now you understand the blueprints.